Hi, welcome back after the summer vacation to the next instalment of Value-Based Healthcast. I'm Nick Wilkinson. I'm a paediatrician who specialises in setting up different sort of services, and this is about value in health, where we're considering equitable, sustainable, and transparent use of resources to achieve better outcomes. This is the first of a three-part series on outdated outpatients, and has been titled From Horrible History to the Art of the Possible. Very fortunate that we have a double act with Sally and Will presenting and answering your questions. Sally Lewis is the National Clinical Lead for Value-Based and Prudent Healthcare, and William Oliver is the Assistant Director, Strategic Programme for Planned Care at NHS Wales Executive. So welcome.
And nice to see everyone back again. I'm Dee Lowry. I'm Head of Value-Based Healthcare at Clontarf Morgannwg University Health Board. And I've really been looking to this three-part series, really been looking forward to it. So without further ado, let's get on with the horrible history, shall we? So over to you, Sally.
Thank you, Dee, and I am loving the hair. Nice new hairdo there. So I'm assuming you're going to share the slide deck for me. Hopefully, are you? Yeah. Brilliant. Thank you very much. I can see that now. Outpatient transformation has been a hot topic for a number of years, really, and especially in these difficult times in the NHS. Many of us are grappling with how we need to transform the way we deliver care generally to patients to meet their needs, and specifically in relation to the model of outpatient care in hospital settings. So we've got a three-part series, as Nick and Dee have outlined, really taking us from the origin of outpatients right the way through to what are some of the problems that we're experiencing as a result of this current model of care, and then on into the art of the possible, how we might do some things differently, which Will is going to talk about a little bit later on. So I thought it would be fun to see how we arrived at this model of outpatients that we're all very familiar with. Next slide, please. So, the history of modern outpatients, I think I tracked down to this place, which is the Hôtel Dieu from Paris. And in the 17th century, the poor of Paris used to come to Hôtel Dieu as cases of charity, and it might have been for social care, but it was also for medical care, which they were able to receive free as long as they were signed off as being eligible for charity. And this model was quickly picked up by some of the London voluntary hospitals. And in fact, the reason that the Royal Free Hospital is so named in London is because it was one of those voluntary hospitals, and people who were having the right to receive charity, as it was then called, were able to have a letter signed for them, and they were able to go along to the voluntary hospitals and receive free care. And in the 17th and early 18th century, the outpatient department was born as a result of that. In parallel, there was another type of care called dispensaries, which dispensed medicine and medical advice, and was probably the early origins of primary care in this country, but people had to pay for that. And so, as you can imagine, people voted with their feet, and they tended to try and go to the outpatients in the voluntary hospitals rather than the dispensaries. And that state of affairs kind of grew, I guess, as it became less of a requirement to receive a letter entitling you to that free care. So they sort of did away with the letters, and then everybody just piled in to outpatients. So as a result, in London, in the London voluntary hospitals, they saw huge growth in numbers by around 1850. And that free access also started the concept of casualty, which came from casual attenders. So people used to rock up without an appointment for any particular issue, accident, emergency, or things that we would recognise as being primary care these days. So in 1853, the BMJ wrote, somebody in the BMJ wrote an article saying the abuse of hospitals and dispensaries is the monster evil of the day. So isn't that interesting that back in 1853 they thought that was the case? And of course it was because of the large numbers of people that were coming along and announced, and we'll talk a little bit in a moment about the pressure that that caused. But of course, most of those people were very, very deserving of care, and there were some quite colourful stories written about people who should not have been entitled to free care using those services. So, for example, middle-class gentlemen would dress in their servants' clothes and leave their carriage around the corner so that they could access free hospital care. So, you know, really, really interesting accounts of what was going on back in the 1850s. And unfortunately, dispensaries, which were probably a precursor of a community-based medical model, never took off. And it was so much that precursor that it was even described how medical training could happen in the community, very much around a primary care model with the specialists coming out into the community, which I thought was fascinating because somebody obviously was very forward thinking back in those days and had already thought of many of the things that we talk about now in terms of community models of care. So all of these facts I found in a very interesting article from the BMJ in 1978 from Dr. Loudon, who was a GP at the time. Next slide, please. So what was the impact of that sudden growth in outpatients? Well, this gentleman is Robert Bridges, and Robert Bridges was a physician in one of the voluntary hospitals in London. He later went on to become Poet Laureate. And he wrote an account of his time as a junior physician working in outpatients in the hospital. And he says that I filtered 30,000 patients per year, 2/3 of them new patients, at a rate of 1 every 88 seconds. Wow. So we think we're under pressure now, but they certainly were not enjoying an easy time back in the 1800s. And so as a result of this, in 1870, arguably the first ever outpatient transformation committee was formed, which I have to say was the first of many unsuccessful attempts at reform. And the biggest barrier really was interprofessional arguing about what should happen. And at the time, the hospitals were not at all bothered to change this system at all. It was really the GPs, the primary care physicians, who were very unhappy about this because, of course, they were attached to the dispensaries and they charged for their care. So if people could access free care through the voluntary hospital outpatient departments, they voted with their feet and bypassed the GPs. And so one of the very first outputs of outpatient reform in this country was to create the referral system. And that was absolutely only to protect the income of general practitioners in the community at the time. So I make that point because I think that many of the customs and practices that we see in the healthcare system today arose for quite arbitrary and sometimes bizarre reasons that are lost in the mists of time, and we shouldn't necessarily consider that it's always the best way to do a thing. Next slide, please. So the criticisms, 1870s style, were the following: that you know, not having enough time led to poor care and mistakes. It was a bad example to medical students in training. There were too many trivial cases. It was abused by people who could afford dispensaries. And of course, it robbed GPs of their outcome. So all of these criticisms, and we see different flavours of those criticisms today, don't we, of outpatients, led to this feeling that outpatients was unsustainable in the 19th century, and they really needed to do something about it. But the things that they did about it were very much driven by medical professionals and other factors that did not really relate to patient need or even resourcing at the time. So I found that really interesting, that this has been a perennial debate, it would seem, around outpatients and the need to reform. And of course, now we have a very different situation. We do have resourcing issues, but we have a population with a very different set of needs, and we're providing far more treatment, far more different types of treatment to lots of different people who are living with chronic illness for long periods of time. So we must think about new ways to involve people in their care. And thinking about doing things differently. But Nick, I thought that was quite interesting to find out where the origins of outpatients and outpatient transformation came from. I think that's my last slide. Oh, no, not quite my last slide. This slide just illustrates that, non-communicable diseases are the problem of the day in the developed world. So heart disease, cancer, diabetes, issues with alcohol and so on. And increasingly we're losing healthy life years. So it's not just about mortality, it's how long we're living with chronic health problems. And next slide, please, which I think is the last slide. Yeah. So to summarise, we have global unsustainability of healthcare systems and outdated system design for very arbitrary reasons. And we have inequitable variable outcomes that bear little relation to cost. So outpatient transformation is a no-brainer. It's just one of the ways in which we need to completely rethink how we deliver healthcare in partnership with patients and the public. And I'm now going to hand over to Will, who's going to talk to us a little bit about the work he's been doing and the art of the possible in outpatient transformation. Thank you, Will.
Hang on a minute, Will. We just might see if there's any questions first from the audience. Just my reflection on what you're saying, Sally. I just remember as a medical student, I did my elective in Borneo. I was very lucky to do that. And we would have 80 patients arrive for 2 docs for an afternoon clinic. And so if you scale that up, that's 41,000 patients if you do 5 days a week. And sometimes these guys were doing 7 days a week. But what they did was I was just fascinated then by the systems, because they would have essentially it's triage. So they would have 2 people there who would then take sputum and blood from every single one of the patients. They would look on the slides and they would rule out malaria and TB. And then that was 60 of the patients. So then 20 went through to the docs. And I thought, wow, that's already a fantastic system. And why don't we learn from that? And I think you're right. We're just learning constantly, aren't we? And trying to take systems from elsewhere. So that was just a reflection from me.
Yeah, absolutely. I spent a lot of my early days running around medical records and taking notes to outpatients, and a lot of it still feels the same in 27 years.
Yes.
So I think it's right. Are we ready for a value revolution, I guess? So everyone who's watching, please, if you've got any questions or comments, pop them in the chat bar and we will pick them up. I think if we go to Will, and then we can have a longer questions section once Will's done his bit on the art of the possible.
Yes.
Yeah, over to you, Will.
Thank you very much. I think Brooke's going to share the slides. I hope you can hear me okay.
Yes, we can.
Excellent. Firstly, thanks for the invite, and it's great to see so many people here. I think internationally compared to just in Wales, so it's good to share some of this work. And I'm conscious as well that a lot of people joining us are embedded across Wales in this outpatient transformation work already. But just wanted to really share a bit of a flavour in terms of where we can get to, but also where we are heading and how perhaps we can try and get to that with a little bit more pace. So I think everybody knows the scene, I suppose, in terms of referrals recovering perhaps to and exceeding then pre-COVID levels, but not necessarily the capacity matching that, which has exacerbated the problem really in terms of our longer waiting patients, and probably put a little bit more of a lever or a driver down in terms of how we need to do things differently and reframe our approach to try and make sure that waiting lists don't continue to grow, but also to make sure that follow-up waiting lists we have within Wales sort of turn the right direction and we're far more efficient, and as you say, gaining value from the system that we work within. On the bottom there, you can see that we've got 360,000 patient consultations each month, and that's not including any primary care or diagnostics. So the volume in terms of the activity going through our secondary care system is absolutely huge or enormous, really. But I think that also gives a much bigger impact and an area that we can try and get some value gain from in terms of focusing our attention collectively with clinical engagement and clinical drive to try and make a difference. I think of those 360,000 patient consultations, a lot of it still is within a sort of an infrastructure, a traditional clinic-based model, which I don't think necessarily is where we should be in this day and age, or certainly where we don't need to be as we move forward. And although the stats on the sort of bottom right there are related to England, I think you can probably glean some proportionality into a Wales footprint if we started to deploy or enact more things like virtual working, and also then reduce and improve our efficiency and increase our productivity in terms of both financial quantum savings, but more importantly, value in terms of perhaps time saving for both clinicians, the system, and more importantly, perhaps patients as well, who in certain circumstances in a traditional model, we are bringing in and making them travel perhaps unnecessarily. Thanks, Brooke. So following on from one of the graphics from Sally, I just wanted to share the sort of equality, equity, and then liberation, almost in terms of, I think we need to remove the barrier on that sort of baseball field analogy, and sometimes the fence gets in our way. And I think if we can all get rid of that, we can perhaps get through to what the art of the possible is. And this artwork I've put in there, I suppose, telling the story of that as well. In terms of, you start off with a bit of a sketch in terms of what the art of the possible looks like. It perhaps becomes a little bit more abstract in terms of Jackson Pollock in the middle. But what we're really trying to get to is the sort of the Sistine Chapel, where every fresco is unique in itself, but they all knit together to tell that coherent story, and it works. But I'm conscious as well with people on the call that sometimes it perhaps is a bit of a scream in terms of perhaps thinking about what we need to do and how quickly we need to do it. Next slide, please, Brooke. So in terms of what the art of the possible is, I think we've got Welsh Government colleagues on the call, but they've really clearly set out a sort of framework and a bit of a travel of direction in terms of the new strategy from 23 to 26. And realistically, what we're trying to do there is, in the blue box, ensure that every interaction adds value, and understanding that that's for both the patient, the clinician, and the system. I just wanted to explore a little bit on the planned care 5 goals, though, as you'll see in the centre of the slide there. And I think that really starts to give us a bit more of that framework to hook some of this art of the possible on. So with effective referral, we're looking at health pathways work in terms of what that looks like, and making sure that patients and clinicians in primary care have a clear sort of route mapping, but also then advice and guidance in goal 2 through to secondary care clinicians to have informed conversations and perhaps more able decision making for what is right for that person, rather than the default model of a referral going in the first place. Goal 3 is treat accordingly, and that's about appropriate access. So it might not be into a secondary care, it might be in community, it might be in the vast ways of professional groups that we have working in primary care as well. I think it's about appropriateness at the right time and right place. Goal 4 picks up predominantly a little bit more choice. So I think that's moving perhaps from traditional models into more of the patient-initiated follow-up and see-on-symptom self-management pathways, which are very different in terms of construct, both for clinicians, but also for patients. But that's something we really, I think, need to progress with even more than we've embedded in Wales already. And that gives individuals a little bit more perhaps sight on their condition and the ability to manage it themselves, but also then the right information to be able to know when, if exacerbation of condition, for example, occurs, they can get the relevant intervention and support when they need it, rather than when the system needs it. And finally, all of this is underpinned by the data and sort of how we measure our progress, both from a problems perspective, but also a sort of monitoring of progress of how we're getting on with some of these new delivery methods. And I think sort of graphic on the right hand side there is trying to look at digital, which I'll come on to in a second slide in a second. So thanks, Brooke. So what needs to change? I'm sure we'll get into this in a lot more debate, and there'll be colleagues on the call that are really familiar with some of this. I think from an outpatient perspective, we have to both not default to an appointment. That's both for new and for sort of a routine follow-up cycle. I think it's really important to have a clear purpose to what any appointment should be and should offer and should deliver then for patients and the system. I think we need to definitely look at increased enhancing multidisciplinary skills and capacity, but also make sure, as this is a value-based healthcast, that all interactions, as I said before, to double down on are actually value-based. Interesting, some statistics on the right-hand side, though, in terms of that sort of movement of clinical engagement and practice as well, and up to sort of a quarter of doctors, it should say, but I think it should probably say clinicians, sort of a 20% level of the new patients don't actually need to be there at all. So if we're continually in that sort of hamster wheel of bringing people in, and we realise that actually that's perhaps an unnecessary visit or appointment, I think we all know that we haven't got the capacity because it's scarce, and also the financial position to not utilise that capacity as effectively as we should do. And it's the same in terms of the 28% at the bottom of that graphic as well, in terms of alternatives to face-to-face consultations, sort of backing what I've just said up, really. I think the art of the possible into the future is looking at sort of more digital enabled, and that's just not video group clinics and virtual working. I think it's the use of AI to start really driving some of that forward, so we can happily get into some of that conversation perhaps in a second. But more importantly as well, or just as important I should say, is the fact that we've got the 3 Ps policy in Wales, which is promote, prevent and prepare, being taken forward by the Welsh Government and the exec and a number of other colleagues across health boards, as you'll be aware. And that's really about active waiting when people do have to wait, rather than that passive waiting, so we can support, inform and also make sure that people are able to self-manage when they do have waiting times to face. Thanks, Brooke. And perhaps one more click. That's great. I think this is my final slide, just in terms of summary. Perhaps looking at what referrals look like in future, and I think we've got to start using our digital platforms to really move us forward in this space. I think we've got things like straight to test and straight to pre-assessment, so cutting out steps in journeys where we need to, along with, as I said before, using multidisciplinary teams. So I think really it's about referral and prioritisation based on need and appropriateness, and moving that forward. That's for new referrals, but I think we really have to break this cycle of sort of traditional ongoing routine follow-up sort of processes, and we see that, and I think we're getting somewhere now with sort of really good nuggets and areas of clinical specialties that are driving some of this forward, but I think we need to put that on a much more robust platform and have clinical drive and peer sort of support to take that forward. There's quite a lot of areas that I'm not probably going to cover in detail on the right-hand side in the green section, but some of those are PROMs, for patient outcome reported measures, that most probably colleagues will be aware of, in terms of understanding how we deliver better, but we understand what the difference is being made. I've mentioned self-management pathways as well before, and I think I've mentioned virtual reviews in terms of both telephone or video clinics live with the patient, but also that perhaps more digital and virtual review of patients on follow-up lists, for example, without the patient being there, to try and understand either a new or a revised treatment plan for them. So in summary, because I've probably run out of time and I'll get a bit of a nudge, I think ongoing opportunities and sort of that aspiration and drive going forward really needs to consider all of those aspects. So it's not being wedded to traditional models, it's looking at digital, it's looking at virtual, it's looking at the way we appoint patients to both benefit the system, clinicians and the patient, so they do get the relevant support at the right time rather than when the system demands it of them. But I think those questions at the bottom there, in terms of the 3 you can see, are probably really important for everybody to ask, from no matter where they come from. So operationally, members of the public, and then clinicians and the system within NHS Wales. Thank you.
That was brilliant. thank you both. That was kept to time, so we got plenty of time for questions. Please, people, just ask the questions you can, and we'll feed that on. Will, that was you covered such a breadth there in such a short space of time. Where would you start? You know, or where if a transformational lead came along from one of our esteemed organisations and said, look, yeah, we just need to improve our output. Where are there 3 things that you would advise that we start on?
I think if I could have some liberty to add 2 extra, I'd add to 5. Probably goes back to those 5 goals, Nick, I think. And you know, if there was a silver bullet, we'd already have done it by now. But I think if we start to look at that pathway approach from how we sort of in primary care, and that's wider than just general practice, it's into community optometry and other professional groups as well, understand and communicate probably better with secondary care to try and get that advice and perhaps guidance and mutual peer sort of conversation, really. I think that starts the journey off for the patient in a probably better way than we're delivering now. I think we've got all the way through those elements I've talked about in terms of really adopting and driving forward self-management pathways would be a real priority for me. And I think colleagues across Wales, we're really wedded to the point of this cast today, isn't it? A really traditional sort of, you must come to a building that houses doctors and clinicians, and therefore we will see you at a certain time that is right for us. I think certainly for either new patients or certainly mostly for follow-ups, that needs to really change quite rapidly. And I think the ability for patients to have more power, control and voice over when they need to have some support and intervention would be definitely something I'd advocate. So I'll pause there, but there are others, Nick.
Thank you. And Sally, you know, just reflecting on where we've been, would you say there were 3 things that just sort of leapt out to you?
Yeah, I think there are 2 main reasons why referrals are made to outpatients, aren't there? One is around diagnosis, you know, to aid diagnosis, or if there's some kind of diagnostic challenge, and the other is to meet a symptom need. So patients have a need, you know what the diagnosis is, but you can't meet that need in the community. So one of the things we've got to be really alive to is how are we meeting need? Because need doesn't go away. You can write as many pathways as you like to tell GPs what to do, but if there aren't alternative ways to meet need in the community, we won't be serving people. Well, we will. So that's a really key thing for me. And the other key thing that really stands out for me, and we've talked about this on the Healthcast before, is that self-management doesn't happen by accident. It's supported self-management. And if we're going to kind of flip from quite a paternalistic style of healthcare delivery to one that's much more co-productive with patients and the public, then we need to give them the tools and information and support to do that. From a coaching perspective, from an actual information perspective, and tools to have flexible communication with their clinical team, for example, or to be able to see their blood tests and track them themselves. You know, we need to put a lot more information back into the hands of patients to support these new models of care, I think.
And so I guess picking up on that, Sally, given the financial context that we're currently in, how do we consider the improvements that we might need in our digital systems, you know, the time to spend with our patients, the information, how do we get that to them at a time when we're being asked to look at our budgets, cut back on everything, and keep what we're doing going in the meantime while looking at this parallel path. So what are the things we can look at in these very tight financial situations?
Yeah, a really good question, Dee, and I can see loads of really good questions coming through on the chat, by the way. I hope you're getting these.
Yeah.
I just got momentarily distracted by some very interesting points there. I think I've been quite involved with the digital landscape, as you know, over the last few years, and my observation would be that we haven't been good at joining digital and data developments with the clinical and patient requirement. So it's like we do a clinical strategy over here, and then, oh, digital, that's IT, it's over there somewhere, and something magical might happen. So of course, if you're not linking your digital and data transformation strategies to your clinical priorities and the investment in those clinical priorities, when tough times come along financially, what are you going to cut? It's digital and data that's going to be seen as a cost pressure. So I think the first thing we have to do is really mesh in with our clinical priorities what the digital and data enablers are to help us to do that, because we can describe all the planned care policies in the world and our aspirations around digital, but if we're not actually meshing the two policies and strategies and delivery together, we're never going to get there. So I think I'd be shooting from the hip here, not sure that it's helpful to have digital funding streams that are separate from planned care funding streams, for example. And I think if they were brought together more systematically, which we are talking about doing in Wales now, I think we will be able to move forward with a limited number of priorities, but things that could be really hard hitting in terms of delivery, particularly in the outpatient follow-up space. I totally agree with Will on that.
So I've got a great question here, which is sort of close to my heart. And it's sort of really around about the use of workforce. And so Ellen Evans has said, should we be encouraging self-referral to community therapies that could cut out unnecessary GP appointments and reduce time to wait for appropriate treatment? And so what do you think are the challenges there? Because I think we'd all agree that that's a brilliant idea. What are the challenges? What would be the expectations of patients? Will?
It's probably better for Sally, but I'll have a go. I think it's a difficult one, isn't it? I think the ability to use our workforce and multi-professional groups and workforce is absolutely critical. So it can't be seen as sort of just cherry picking and getting through to the wrong professional group. And also, I think sometimes we do put layers in where we perhaps direct either patients or a flow through multiple elements and layers, and then it just goes on to the next, whereas actually you could probably skip some of that or not have it at all and hold it back at the first one. So I think that there's a different approach to using multidisciplinary workforce in a better way, and I think we've probably got more room and definitely more need to sort of join some of that stuff up, so it's not seen as you have one element of intervention here rather than the holistic sort of how can we try and do everything as much as we can, perhaps in the single appointment or in the single space in as short amount of time as possible.
And I think what some patients may be worried about is they presenting with a symptom and they think, oh, we just need the therapies, when actually there might be a symptom complex where perhaps a GP might be better suited. And so we're always going to have that element of risk, but until we change the system. But then also we have to have, and I think this is what we're doing at the college, is thinking about, well, if they see say a pediatric physio first, what is the link back in, and then how quickly can you come back in? And so therefore there needs to be much richer workforce planning around that and understanding. But anyway, brilliant.
Yeah, so sorry, Will, go on.
Going to say, I think certainly an element of safety netting there as well, because it isn't just a discharge straight back to primary care, move the demand or to where the capacity isn't. So I think it does need to be joined up, absolutely. I'd agree with that.
So I'm going to pick up on a couple of questions that sort of relate to that area, and often primary care is seen as a bit of a gatekeeper. We all know the analogy of a primary care receptionist, whether it's right or wrong. But we've had two comments come through from John and Alan. So John's one was, Sally, given your point that secondary referrals to secondary care were created to protect the income of primary care, should Wales consider a model more like Australia, where patients can self-refer to secondary care as well as still accessing consultants via referral? And Ellen has also, in a very similar way, said, should we be encouraging self-referral to community therapies? Oh, is that okay? Yeah. Right. So linking on from the primary care one then. So should there be direct referrals from patients into secondary care as well? Or is that a step too far?
So it's really interesting, isn't it? And John, it's funny, isn't it, how it's flipped now? Because I would say that probably GPs are now suffering from that earlier intervention that they put in place in the 19th century, because they're certainly not incentivised in the same way these days. Self-referral, I think, is really interesting. I think it definitely does have a place. I've got some experience of it in terms of arranging self-referral for patient self-management services in osteoarthritis back in South East Wales about 10 years ago, and it can be incredibly effective. I think Catherine Roscoe nails the answer here in the chat. So Catherine says, this would be ideal for managing ongoing lifetime conditions. From personal experience, my prescription orthotics always wear out or break just outside of the patient-initiated follow-up timeframe, leaving me with a 2-week wait to see my GP to get re-referred, and then another 8 weeks to be seen by podiatry again, which is nonsense, isn't it? The difficulty, so that's a brilliant example of where self-referral would be absolutely logical and efficient and much better experience for patients. The difficulty with self-referral is that it doesn't work everywhere, and Nick has alluded to one of the reasons why. So patients often come to GPs with undifferentiated symptoms, and they may not know that they're undifferentiated symptoms, and therefore may well select the wrong specialist to go and see. That's not me being paternalistic, that's just fact. Diagnosis is really difficult, even if you've had years of training in it. So self-diagnosis is difficult. And with the increasing subspecialisation of our hospital colleagues, that potentially could lead then to the poor person having to go to another person and another person. Of course, there's inefficiencies in that, as well as delays in diagnosis and poor experience for the patient, which we would want to avoid. So, and Australia, interestingly, is kind of suffering a little bit from this now, because they have quite a lot of fragmentation of care in that country as a result of this and other factors. So I think the question is, if we all agree that self-referral is a helpful tool, and I think we do, where is it going to be most helpful? And, you know, let's start with those segments where we can just get on and do it, and then think, you know, particularly in the diagnostic space, how we would manage that sensibly, both to avoid misdiagnosis or people having to be pinged around a system to see multiple professionals. And that might be a way to go.
Nick, the next one.
Yeah, so I've got another great question here. So how do we enable older population really to access care? And I think here it's referring to virtual clinics, but I think again is thinking more broadly. Any thoughts there, either of you?
I think from my perspective, Nick, we can't expect everybody in the population to have access to digital means within their own home, and appreciating, you know, there's a mix of variability in terms of how people can and would prefer to access services. I think what we need to be doing, though, is a little more proactive into those perhaps groups or cohorts of people that perhaps don't have access to that, and it doesn't necessarily need to be on a one-to-one basis. So we've got really good examples of video group clinics where, you know, people are willing to, you know, get either support or a bit more advice in terms of perhaps a physio space together. Certainly Joint Schools is working really well in that space in terms of prehabilitation prior to procedures in orthopedics. I think that there are a couple of comments I've already seen there as well in terms of perhaps using community hubs in that space as well, where you've got more private space, but the actual digital enablers are provided for you. So you can still have that conversation with your clinician as long as you're able to access that. And that's probably more based in communities, appreciating that doesn't touch everybody with perhaps more mobility issues, etc. So there isn't a single answer, but I think there's definitely things we can do and take forward that will perhaps increase our reach with some of these services, definitely.
And so one of the challenges for me is, you know, I try and change the way I deliver outpatient. So I'm an outpatient special service. Is the rigidity by which we collect our metrics. And so I need to see 9 patients or 16 patients in an outpatient clinic, which is this amount of time. And we know all patients need different amounts of time, and obviously we balance our clinics accordingly. But it doesn't matter which service we go to. So if I'm talking to some orthopedic surgeons about how to better manage persistent pain, and they go, oh, we've only got 2 minutes. What do you reckon you're going to do in 2 minutes? And I say, well, don't do it try in 2 minutes. Change your appointment time. So we're fixed in our behaviors by the system we have. So how do we go and change that? How do we change the sort of the rigid templates? And, you know, because we have financial incentives to see more patients, and so therefore we keep it short. So there's loads of things that are constricting us to this particular pattern. Can you see how we disrupt that? Well,
So I was actually thinking on this, and as a patient, when we contact them, we just tell them when to come, don't we? As you were alluding to earlier, you know, we say, right, come along at 9:30. We don't care if you're working or you've got other things. That's the date. And if you can't come, then give us a call and we'll get back in contact with you whenever you hear from us. I think a movement to some of the booking systems has changed some of that. But then again, it is to you've got your 10 new, you've got your 5 follow-ups. So the patient initiated follow-up is really important, but you need that information on symptoms to see whether you should be seeing them earlier or not. But I think starting to think about the patients and asking them how they want to be communicated with, whether they want to be coming in and logging the information. And then it sounds like a lot of work at the front end, but how do we then create the clinics around what the patient needs and how they want to be communicated with? So whether it's a group session, whether it's patients that do want a morning online, Nick, or whether, you know, we are out in the clinic for the ones you think we can do in 7 minutes. We haven't really thought about segmenting our patients in that way, with understanding how they're best to communicate with, or what we need in order to see them. Do you need diagnostics? Is there a diagnostic delay? Have you got all of the information in front of you? And also, do you have time to go through, if we get that remote monitoring information, to say, okay, I don't need to see that one, don't need to see that one, yeah, I want that one. Whereas at the moment, it's much of a, okay, we'll see you in a few weeks, because that's what your expertise is telling you face to face you need to do.
I completely agree with that. I think it's not easy, is it? But we have to start to identify those perhaps preferences. And we're not very good at that anyway, in terms of just communication preferences. You know, how we communicate to perhaps someone on an ophthalmology waiting list is very, very different to other specialties, because they can't necessarily get that letter and get the appointment. So we really need to refine that. And then the bit around trying to work that into templated capacity, Nick, is a difficult one. But when you've got more segmented cohorts and identification of patients, it becomes a lot easier. So I don't think we can use that as an excuse not to, really.
Sally.
So Nick, your question was about, you know, what are the barriers to doing things differently, I guess, isn't it, at scale? And culture and context is obviously the first barrier. So we're also ingrained in those ways of working. Patients, clinicians and organisations and policy expect, you know, have expected a way of working. So it's quite hard to change such rigid systems culturally. So there will be resistance from people. There's a very human aspect to this. I think also lack of understanding of the problem. So in Wales, we do not have good coded data as to who exactly is waiting and why. And we should have, and we actually do have some digital systems already there that could help us to do that if we were fully utilising them. So, you know, we should be making a push on that. Again, that's a cultural thing and a cultural change, but we could do that. And then I think that would start to help with segmenting the need, as you were just suggesting, Dee. And then we can start to get into, well, what's the most appropriate approach for different groups of people, and how do we maintain a different approach for people who are digitally excluded? You know, how do we do follow-up for chronic disease as opposed to follow-up for an episode of care like a joint replacement? You know, there will be lots of different contexts, won't we, that we can start to have user stories around, and I think that would really help us segment the work. Otherwise, we're trying to eat the mammoth with chopsticks in one setting, and it's just impossible, isn't it?
Yes. So
did you want to pick up? Have you got Keely's
Yes, we've got Keely says, do you think there needs to be an element of patient optimization prior to an outpatient appointment? And I guess this could be in terms of a surgical review, perhaps reducing BMI, improved diabetes control. And so I guess this is about triage, sharing of information, and prioritization. And I just have you got any reflections on that, either of you?
Yeah, I mean, I know Will will want to come in on this in relation to the 3Ps programme and what planned care are trying to do there, but there are some other questions in the chat that I think relate to expectations of the public around what healthcare can do for us. And I do think that there is a need for some honesty with the public around that. And I'm not talking about turning off services or, you know, running out of resources particularly. I'm talking about how we can't expect just to be fixed all the time. We all have a part to play in fixing ourselves. It's a partnership. Getting a good outcome is a partnership between the person receiving care and the team giving it. So any surgical intervention is going to have problems attached to it if the person receiving that surgical intervention has not done all they can to prepare themselves for that surgery. So we do need a broader conversation that sits outside of healthcare, in my view, around expectations of healthcare, you know, health literacy, and you know, why that is so important in getting a good outcome, and also for people to understand that if we want to be able to afford new technologies and new treatments as they are coming through from the pharmaceutical industry or somewhere like that, then it's incumbent on us to do our best to minimise our use of resources in the healthcare system elsewhere, because there's an opportunity cost to everything. So if you're coming and expecting the healthcare to fix you for a particular problem that you could have fixed yourself, I mean, I'm thinking about the Victorian gentleman who left his carriage behind around the corner to go to Outpatients in London. Not suggesting that's happening in Wales at all, but what I'm trying to get across is we have a responsibility. If we believe in a free NHS, we have to learn how we all protect it as a collective so that we get what we need when we need it to keep ourselves and our families as healthy as possible.
And picking up on that, Sally, so do you think we push back enough? Do we willingly accept whether it's a patient saying I want a referral to a specialist, whether it's a GP saying oh I'll pop a referral in, or whether, as we were just saying, 20% of patients don't need to be there? Well, how do we unpick that? How do we go, well, who are the ones that are coming through and how are they getting through and how do we push them back? Now, I've been in A&E or outpatients before, and you're there and you're going, that really doesn't need to be here, but nobody wants to be the person that says you don't need to be here. Now, clearly, if it needs diagnostics or something, that's fair enough. But where there are obvious things that could be pushed back on, I think we need to be stronger and actually do that in an informed way with clearer pathways on what is acceptable or what's not acceptable. If somebody's not optimized to the point that secondary care is going to be they're going to be ready for the intervention, then how do we make sure that they are being pre-optimized in primary care, ready for when they're seen? Now, with current waiting times, that makes it very difficult because they're going to depreciate from the point that they're referred anyway, going back into primary care, which could then, they could be ready at the point of referral for an intervention and then not ready by the time they're seen. So we've got to work a way out to manage that bit in the middle, haven't we, of what's actually happening with that patient. And as you've said, what more could be done, Will? And I think that goes back to your 3Ps.
It absolutely does. I think my colleague from Welsh Government, Liz Davis, has put the 3Ps programme in the sidebar there. So I definitely suggest that everybody clicks on that and gets a bit more detail. But I think it's promote, prevent and prepare for planned care. But that's not just planned care pathways. It is almost that prevent element in terms of the population health aspect. And I think, we can get into that space in terms of both almost patient contract and responsibility, as Sally's alluded to. And I think we definitely need to be stronger in that, because long-term conditions in diabetes. We could have multiple areas of demand and ever increasing demand into certain conditions that are probably preventable in the main. It's a challenging both economic and socio sort of circumstance that we live in at the moment as well, though, that doesn't necessarily help that. So the challenges are increasing to get into perhaps more entrenched areas of either economic issues or otherwise, but we have to do that, otherwise we'll just be on a recurring wheel of ever increasing demand. I think, as we've alluded to earlier, though, how we properly articulate and have enriched conversations with people who are in the system, now whether that's primary care or secondary care, the 3 Ps is really starting to get into that space. So it is about making sure that you are well enough, or as well as you can be, to have a surgical intervention. Therefore your outcomes are better, therefore you stay in hospital, and therefore wider clinical risks around potential complications and infections are reduced as well. So all of that piece needs to knit together to try and sort of improve where we are, but with the expectation that I think we can't deliver everything for everybody, and that needs to be a message that's loud, heard loud and clear as well, I think, because the expectation ever increases, but clearly our service delivery can't really.
Absolutely, and I think that hamster wheel approach is really important for the consideration as well, isn't it? Because in order to have a mutual relationship with the patient, we need to be thinking about their health literacy, which goes back to the organisational culture and time with patients, them to understand the condition and what they need to do about it. But I also think it pushes further upstream as well to our education in our early years, or we're forever going to be on this hamster wheel, and I think there's a wider opportunity with those wider determinants of health, with housing, with education, to make sure, that we're getting that understanding coming through until they're coming up to the chronic illness ages, where we're back to where we are again. And
sorry, Sally.
Dee's kind of made the point for me, really, which was, I was just going to say, in my GP days, people, if people come to where we perceive is the wrong place, that's our fault, really, yes, generally speaking. So it means that that person doesn't have the right information. They just need help, right? So we need to figure out how we don't disadvantage people who need help and who have inadvertently gone to what we perceive as the wrong place. So that links to the earlier point around supported self-management as well. We really need to be far better at flooding society with information around how to access healthcare, how to look after yourself, what our responsibility as citizens is in healthcare. And in terms of your point, Dee, around being more forthright perhaps with people, I think was what you were kind of saying. It's really hard for clinical teams to do that when that message is not supported either organisationally or politically. So if we're going to have that type of really honest conversation about what the NHS is there for and our collective responsibility to keep it going, everybody needs to be saying the same thing. And I appreciate that can be very difficult in different sections of society and the public sector.
I think we're potentially coming off topic here, because we can talk about wider determinants of health and how we need to have connections then with education and with social care and everything else. But actually, we're actually talking about outpatients here. And so it's just coming back and making sure how are we optimizing that use and delivering care in different ways. And we've covered that in numerous ways, the way that we can use different time slots with different personnel, just to explore a bit more just around the use of digital. One of the areas that's really interesting for me is the use of digital triage. And so we've got tools like Promise, where in 4 questions you can identify how anxious a person is or depressed they are, which then contributes to their symptom perception. How quickly could we introduce that into a triage model? Do you have any ideas on that? Will, are people using that already?
I think they are, but it's probably once again limited, and it comes back to the conversation we had before. There are so many solutions that sort of come to the fore, either procured exercises or private companies, or just simple tools that you could add in. I think we've just got to really consolidate and focus into something that will make the biggest difference and biggest impact. So Sally's probably closer to the digital space than I am. But yeah, that would be my thoughts. I think we need to carefully select, but then absolutely adopt and deploy consistently these tools that will make a greater game.
And I think that also links back to the DNAs, doesn't it? Because if we're able to send patient reminders that they've got an appointment coming up, as I know some health boards do, but in some health boards do it right the way across, some specialties do it in different areas. Do we not need an all Wales solution that, you know, has this reminder system for patients if we want to achieve that 2% decrease across Wales?
See, Sally's eager to come in.
Nicely set up. No, yeah, two quick points really, one specific and one more general. So can we use things like Promise to triage attendance at outpatients? Absolutely, you know, so patient reported outcome measures are basically structured, codifiable sets of communication, aren't they, between a person and their clinical team around their burden of symptoms and their quality of life. So that really enhances a virtual communication, I think, and helps people flag to their clinicians how they are in quite a lot of structure and detail. And that's just one tool, of course. There's a whole suite of information sharing we can do digitally to support remote care for those that want and need it. And I think, so on that note, then the general point I want to make is back to my earlier point around how digital policy and funding has historically been over here and clinical policy and funding over here. What that is resulting in now, unfortunately, is a slowing down of the development of the NHS Wales app, which is the single gateway for patients to come into digital services, as you know, Dee. And that risks fragmentation of digital implementation across Wales, which would be less efficient, but you know, we'll be left with no choice but to do that because of the need to quickly transform outpatients, I think. So I hope that we can start quickly thinking about how we link the planned care programme to the digital services for patients and public programme, both in terms of strategy and funding, to really address some of these tools that the teams are crying out for to implement these new models of care.
I think just one more reflection, if I can. We can talk about changing, and we are changing how we work. But I think we could invest a lot of time doing that to the people who are currently in our system, without then missing the element around training. So ultimately, we've got people coming through either medical school or other professional sort of qualifications into the service, and they will be currently trained in a quite traditional model. And I think we've got to sort that out as well, because otherwise we'll just have to do the work, reinvent the work over and over. So it's got to be both. We've got to change what we're doing currently, but also make sure that new model of care is embedded for those coming through and into the service.
Across the breadth of all our staff.
All professional. Yeah, absolutely.
Absolutely. Yeah. And I think picking up on Magda's point is really, and bringing it back to value-based healthcare, because I can see the time ticking away. It's been fascinating. It's just been, obviously, we can't just tackle outpatients in isolation. You know, we've got to look at that whole systems approach. But again, we've got to take those small bites, link up where we can in order to move that forward.
I can completely agree with you, Dee. I think I'm going to be biased, aren't I, naturally? But I think we've got a bigger opportunity to gain some bigger impact in outpatients to start with. But yes, absolutely, it's got to be whole system.
So we've got just a minute or so left. I just want to say thank you very much to you both, Will and Sally. It's been a fascinating one, and it's such a huge topic, and it's so easy just to keep going. But we do have two others where we've got people then talking about their experience of changing the system for outpatients, and then we've got a live one where I'm going
to be hosting a live workshop. So we're actually going to run through a live version of how we can review a current pathway from different perspectives, and then together, so this one's interactive, we'll be identifying some of the ideas, solutions and the impact to see if we can hit some of those targets that Will's been talking to us about. So the next one is now on the 27th of October. The third session is on the 24th of November, so you'll automatically have been registered for those. And I'm going to give you a heads up as well, because following our third session on the 24th, on the Monday, week commencing 27th of November, we will be launching, we'll be holding Value in Health Week. So this will be a whole week dedicated to value-based healthcare, where you can come and find out more. There'll be the introduction level, but also some really in-depth stories. So as we find out more information, we'll make sure to share that with you on our next podcast as well, Nick.
Yep. So thanks again, Will and Sally, and
thanks everyone
all for joining on this podcast.
Yeah, thank you.